All right, so our presenters for today, we have Sophie Aaron, who's the Research and Program Coordinator at the University of Maryland Safe Center for Human Trafficking Survivors. Sophie helps develop and support the Safe Center state and local task forces work, public health research and program implementation, as well as the survivor leadership programming. She also works to support the crisis intervention team. Before joining the Safe Center in her current role, Sophie interned for a year at the center in a similar capacity while pursuing her master's in social work. Next, we have Dr. Jessica Voles. Dr. Voles is the clinical director of forensics at Adventist Healthcare Shady Grove Medical Center. She holds a Doctor of Nursing Practice, Bachelor of Science degrees in both nursing and behavioral science, and is a Nightingale Award winner. She's a nurse practitioner and has worked with patients across the lifespan for more than 10 years in critical care, emergency nursing, and as a forensic nurse examiner. She's co-chair of the Victim Services Subcommittee for the Montgomery County Human Trafficking Committee and co-chair of the Medical Subcommittee for the Maryland Human Trafficking Task Force. Next, we have Dr. Joyce Williams, who is co-chair of the Medical Subcommittee underneath the Maryland Human Trafficking Task Force. Dr. Williams received her Doctor of Nursing Practice from the University of Tennessee in forensic nursing and master's degree in forensic science from Oklahoma State University. Her clinical experiences include nearly 20 years in critical care and the emergency department, plus 13 years at a child advocacy center. She has instructed students in forensic science and developed and taught the forensic nurse certificate at Johns Hopkins School of Nursing. Dr. Williams serves on the Maryland Human Trafficking Task Force Victim Services Committee and co-chairs the Medical Subcommittee. And finally, we have Dr. David Williams. Dr. Williams received his dental degree from Temple University and master's in public health from West Virginia University. He was on active duty in the Army for 12 years, including 3 years as the dental surgeon of the 10th Special Forces Airborne. He's a retired colonel. Dr. Williams is the co-founder of the Mid-Atlantic Prevent Abuse and Neglect Through Dental Awareness, or PANDA, that teaches healthcare professionals identification and response to cases of interpersonal violence. And with that, I will turn it over to our presenters. And first up will be David Williams, and I will make sure you're unmuted, Dave. Okay, you should be able to unmute yourself, Dave.
Great. Okay, can you hear me?
Yes, loud and clear.
Okay, good. Well, I'd like to thank you for taking your time to gain information regarding this important topic. This training was developed by members of the Maryland Human Trafficking Task Force Medical Subcommittee and is being provided by the University of Maryland Safe Center, the Maryland Human Trafficking Task Force, and sponsored by the Maryland Hospital Center. We report no conflicts of interest. As you've seen and heard throughout the presentation, we will be having polls where we'll ask you to answer questions that help us determine your level of knowledge and help improve services for the victims. Next slide, please. This presentation is accredited by the AANC for 1 hour contact of continuing education. Next slide, please. We want to give you a language disclosure before we begin. Over the next 90 minutes, you'll hear us use the terms victim, survivor, client, and patient somewhat interchangeably. We want to be clear that victim is a legal term, but how someone identifies themselves is up to that person. There are many myths and misunderstandings regarding human trafficking. Who is trafficked? Men, women, girls, and boys, all races and ethnic groups. How are they controlled? By force, fraud, or coercion? And where does it happen? Everywhere. Next slide, please. Should be a poll. Is there a poll question there, Jane?
Just launched the poll. Thank you.
Okay. You see here the legal definitions of human trafficking. It can be divided into groups: sex trafficking, labor trafficking, and organ trafficking. Note that the definition of sex and labor trafficking are similar: the recruitment, harboring, transportation, or provision of the person by force, fraud, or coercion. Sex trafficking also includes those patronizing or soliciting a person for a commercial sex act. Note, in the case of minors, force, fraud, or coercion are not necessary to be considered sex trafficking. Organ trafficking is not directly addressed in the laws. Next slide, please. There are three elements of trafficking: the act, which includes recruitment, transportation, harboring, or transferring the victim; the means, threat, force, coercion, abduction, fraud, or deception; and the purpose, prostitution, sexual exploitation, slave labor, organ removal, or other exploitation. Poll question, please. Okay. Next slide, please. Here are some estimates of the extent of the global problem. 16 million in forced labor. Have you ever thought where the clothes you buy are manufactured and the working conditions of those who made them? 4 million live in state-imposed forced labor. 4.8 million are sexually exploited. And traffickers earn about $150 billion a year in illegal profits. To put this into perspective, this is greater than the gross national product of Guatemala, Oman, and Panama. And if it were a country, it would be 72nd of the 185 countries worldwide. Next slide. National estimates show that hundreds of thousands are trafficked a year. Hotspots are the coastal states of California, Texas, Florida, and New York, and the interior states of Ohio and Michigan. Note that two of these states, New York and Florida, have Maryland being positioned in the middle along Interstate 95. Next slide. This is a so-called heat map of the US provided by the Polaris Project, indicating locations where contacts with trafficking victims have been made. You can see that the locations are often in major metropolitan areas, but some are in less populated areas such as Colorado and Nebraska. Next slide, please. Maryland is 19th most populous state, but 18th in reports to the National Human Trafficking Hotline. As stated previously, the I-95 corridor provides easy transportation through the state and is a frequent stopover. Transportation hubs like rest stops, truck stops, airports, train and bus stations provide transportation and target-rich environments for recruitment of the abuse victims. Next slide, please. Here's a heat map of Maryland. Note concentrations in Baltimore City and Montgomery County. Baltimore City is a hotbed for sex trafficking, while Montgomery County accounts mostly for labor trafficking and domestic servants. While worldwide labor trafficking is 3 times more prevalent than sex trafficking, in Maryland, labor trafficking accounts for only about 40% of the cases brought to the state prosecutor's office. The largest award in a civil case of labor trafficking was over $1 million for a case of a domestic servant in Montgomery County. Next slide, please. These are some popular images of human trafficking. We see Jeffrey Epstein in the upper left was probably the poster boy for human trafficking, but his focus on young girls may cause us to overlook other victims groups, men, boys, and also labor trafficking. To the right, we see the archetypical pimp, which again is a focus on sex trafficking, but in many cases, the trafficker is not a stranger, but a friend or even a family member. While victims may be restrained as part of being trafficked, most often they are more emotionally or monetarily tied to the trafficker. We see here the stereotypical young white girl being subdued by the hand of a man of color, an erroneous stereotype. And finally, on the bottom, we see a clip from the movie Taken, which hits all the wrong buttons for trafficking. In the movie, a young white girl goes abroad only to be lured by a strange man of color into bondage and sold to Middle Eastern men. This, again, is far from the general truth and diminishes the role that close friends, acquaintances, and family can be perpetrators and totally misses the realm of labor or organ trafficking. Next slide, please. This slide represents more of the reality of human trafficking. Young girls are often recruited by family or friends for the sex trade. The internet and social media are not only ways traffickers attract their victims, but also connect those victims with their abusers. Drugs and violence are often used to control the victims. As noted earlier, domestic servitude and field labor with little or no compensation are areas that make up 40% of traffic victims in Maryland. And transportation hubs, and particularly truck stops where so-called lot lizards can ply their trade, are locations for human trafficking. Next slide, please. The medical subcommittee of the Maryland Human Trafficking Task Force, in collaboration with the Maryland Hospital Association, has developed the SERVE model, which we will present today to help medical personnel identify and respond to the problem. SERVE stands for S, serve, the use of trauma-informed practices. I, identify, training to staff to identify victims or survivors of trafficking. R, respond, provide options for survivors to be referred to in the community-based providers. And V, evaluate. I realize this is a bit of a stretch as far as linguistics, but the evaluation portion is critical to collect and analyze data to help make improvements in services to the victims. Now I turn the presentation over to Sophie, who will give you a more detailed description of SERVE.
Thanks, Dave. Okay, I trust everyone can hear me. If you can't hear me, send some messages in the chat. I'm really excited to get to present this first section, our SERVE section, the recommendation that healthcare facilities adopt trauma-informed practices when working with survivors of human trafficking. We put this as our first section because it's kind of like an umbrella topic. The SERVE, the trauma-informed aspect of working with a survivor of human trafficking, will set the foundation for support and will also ground a provider throughout their work with patients who are suspected victims of human trafficking. I noticed that in our pre-test poll, that about 3/4 of our respondents noted that they were hesitant or not confident on how to provide trauma-informed care to victims. So I'm excited to be able to hopefully shed a little bit of light on that. All right. So I'm sure that some of us, maybe most of us, maybe all of us, have had some training on what is trauma. I want us to start out with a little bit of this Trauma 101 because I think it's important. So trauma is a response. It's not an event. It's the ways that we respond when our experience of threat or harm outweighs our capacity to cope in a healthy way. Our trauma response is what happens when we couple fear with helplessness. So I like to think of this pretty basic example of being chased by a bear, which hopefully isn't happening to you all in hospitals, won't happen to you all ever, but for the sake of the example, bear with me. So we're being chased by a bear. Imagine you're being chased by a bear, and that bear is chasing you down the street, and that bear chases you into the hospital. It chases you into the emergency department. It chases you through triage and into the exam room. And here you are in the exam room, and that bear is standing right next to you. So when we're being chased by a bear, we have these trauma responses of fight, flight, freeze, or fawn. Fawn being that we jump to please to avoid conflict. So imagine you're in the exam room and you're having that trauma response of fight, flight, freeze, or fawn, and your bear is standing right next to you. Your trafficker might be standing right next to you. Imagine if the trafficker is not standing next to you, but you feel their presence all the time. Imagine you're having the trauma response of fight, flight, freeze, or fawn in the exam room with your provider, and your provider doesn't realize that that's what's happening for you. So what we are trying to impart to you all today is a basic but important understanding of trauma, and then an important understanding of trauma manifestations, even if you or even if we as providers don't see a trauma present. We're trying to help everyone contextualize a trauma response, how a patient might present in your medical setting if they're a victim of human trafficking. So what we know about victims of human trafficking is that often they will not have a linear process. These trauma manifestations, trauma responses, these will not be our simple patients. This will not be someone who comes in waving their hand saying, I'm a victim of human trafficking, present all the correct indicators and you'll be able to flag. It will be nonlinear, and that's okay. We are here to expect that and to raise awareness about that. Unfortunately, what we need to do to really address trauma and really support our victims of human trafficking in a healthcare setting is to understand what's happening for them. It is to serve them. That's why we call the section serve. We need to serve our patients. And what we need to do that is to transform our medical settings into places that optimize patient comfort and places where we are able to establish rapport and trust with people who are suffering in isolation. Now, it's a bummer because these systems of trauma-informed care, these settings that will allow trauma-informed care to thrive, are often in direct contrast with the trajectory of American medicine. We have increased corporatization, we have diversion of healthcare dollars into private profits, and we have a focus on the efficiency of care rather than the efficacy of care. And so what our SERVE section in our SERVE guidelines is about, it's really just some tips and some tools for you to have in your tool belt so that you can make the most of the time that you have with the patient. You can gather necessary information, you can avoid re-traumatization, and something that you all can implement whether you're in the fast-paced emergency department or you have a little bit more time with the patient. These are just a couple of quick and dirty tips and tools to help you be trauma-informed regardless of your medical setting. So SAMHSA has a lot of really great resources on how to be trauma-informed. They have a lot of really great resources on trauma. And I'm going to kind of work through some of them that we've highlighted in our guidelines here. So what SAMHSA helps us understand is that adopting a trauma-informed approach, it's not something that's accomplished through any single particular technique or any single checklist. It's something that requires constant attention. Being trauma-informed requires caring. It requires awareness. It requires sensitivity. And it might require a large-scale cultural shift, which is a huge ask, regardless of the size of your institution, certainly a huge ask for any hospital. So we're not asking for that. What we are asking for is just an awareness of, as I said before, some of these tips that can help you as a provider be trauma-informed with your patients. So the first is this victim-centered approach. And this is a key partner to trauma-informed care. And what this is about is taking a patient's wishes, taking a patient's well-being and their overall safety into consideration at every step of their treatment. We would ask that you try to impart calm, take your time when working with patients who you suspect might be victims of human trafficking. Take your time as best you can. We know that time does not always allow for a long time to be spent with every patient, but see if you can impart that sense of calm, even if you have just a few minutes to spend. Craft a plan of safety to avoid secondary trauma and professional burnout. Take care of yourselves. This is a hard time for everyone. This is a heightened hard time for our medical professionals, and it will be even more heightened for our victims of human trafficking. So you will know what this plan looks like. You will know best how to take care of yourself. It can include things like eating well, getting enough sleep, know your limits, know your boundaries, acknowledge your reaction to stressful and traumatic circumstances, and then take the time to cope with them and process them. This is heavy work, and we need to take care of ourselves so we can take care of others. Be conscious of your language. Avoid words that might be triggering. Avoid words like trafficking, exploitation, and slavery. Instead, focus on safety. Screen for safety. Don't get caught up in human trafficking in that language. Our job is not to get a positive disclosure of human trafficking. Our job is to support the patient in getting their identified needs met and then helping them make a safety plan. So stay focused on safety, stay away from trafficking if you can. All right, this next one, this is a big one. Trust. Trust the patient. Trust their stories. Trust their symptoms. Listen to all of their symptoms if you can. Headaches are important. Insomnia is important. Often as providers, we assume that our patients need to trust us. We are the ones with the training. We are the ones with the knowledge. Really, it is us that need to trust the patient. As you saw in the previous slide, these might be folks who are suffering in isolation. This might be one of their only opportunities to have access to support. Please trust the patient. And confront your own biases. Confront the bias that Dave mentioned before about who, when you think of human trafficking victim, what is the image that comes up for you? Confront that, because I can guarantee, almost guarantee, that it is a much broader image than we were previously thinking. Let the patient lead the process. That's part of being victim-centered. Let them lead their nonlinear process if that's how it takes. If that's how it takes them, let them take control in their medical process. And then I would say that our goal is not to rescue. Our goal is to create a safe and a non-judgmental space for a patient to talk about their concerns, to talk about their experiences. We as providers might encounter survivors and victims who are not ready to leave. That's okay. The trauma-informed approach says that we are there to give them the tools and plant some seeds that might ultimately lead to change. The best thing that we as providers can do for patients who keep showing up in the ED, who keep showing up for recurrent STI tests, who keep showing up with those headaches, with those stomach aches, is to keep showing up for them. So I would really ask that you do that. So this is a lot of information. We've broken it down a little bit more to these 4 themes of communication, validation and empowerment, transparency, and like I said before, maintaining a calm environment. This is kind of our overview of how to be trauma-informed. Be informative, do not be inquisitive. Be patient, be mindful of trust and power dynamics. On a population level, victims of human trafficking have had control taken away from them. Be conscious of how a power dynamic between a doctor and a patient might reinforce some of those control and power dynamics. Validate and empower your patients when you can. An example that I like to give is often we hear about victims of human trafficking showing up in medical settings, presenting with aggression. These might be the patients that we are not so excited to work with, to treat. If you can, validate that aggression. We say things to our clients like, you know, you're angry. I see you're angry. You have developed a skill of anger. You've honed the skill of anger to keep you alive. This is your survival anger. And, you know, I commend you for that. Be transparent when you can. Be transparent when you are making recommendations about reporting. Be transparent when you're introducing new providers. Be transparent about the limits of confidentiality, and use trauma-informed interpreters. Often, as Joyce will talk about in our next section, a major indicator of human trafficking would be when a patient presents in a medical setting with someone else with them, when that other person is reluctant to leave, and we see that other person often wants to translate on behalf of our non-English speaking victims of human trafficking. Don't let them do that. Get a trauma-informed interpreter. Get an interpreter from the hospital. If you can train your interpreter on human trafficking, that's even better. Please don't let someone else who accompanies the patient into the ED translate for them. And then as best as you can, again, maintain the calm environment. Minimize your sense of hurry when you can. And if things feel like they're getting out of control, refer the patient back to the here and now, focus on what you're doing right now, tell them why you're doing what you're doing, and try to keep them engaged as much as you can and not flashing back to the past. We do not want to trigger, we do not want to re-traumatize our patients. So what I want to leave you with is this PAIR tool. This is an evidence-based framework for assessment for human trafficking, other forms of IPV. It's based on our universal education approach. It is trauma-informed, it is patient-centered, and overall, it recognizes that what we want to do is to create an emotionally and physically safe context for disclosure, a safe context for talking about safety, and that is more important and more effective than using a checklist screening tool. So our PAIR tool is an acronym, stands for Provide Privacy, Education, Ask, Respect, and Respond. It's a resource for physicians, for social workers, for nurses, other healthcare professionals on how to provide trauma-informed assistance to patients who are high risk or patients who are exhibiting symptoms of abuse, neglect, violence, human trafficking included. The tool was created as a guide for a conversation. What it's about is informing the patient of their options. Someone needs to tell the patient what is available to them and then include the patient in their decision-making about their safety and their well-being, and not making decisions around them and not making decisions for them. So while the healthcare setting is this incredibly important point of intervention, this might be one of the only times that this victim has contact with folks outside of their trafficking network. The medical setting, as I've mentioned, can also be re-traumatizing. After this training, Jane is going to send out resources. The PAIR tool will be included. I encourage you to look at the PAIR tool as a guide on how to open up conversations with your patients who you suspect might be victims of human trafficking. So with that, I'll pass off to Joyce. She's going to work us through our identify section, tips for recognizing when we might be seeing human trafficking in the healthcare setting. So Joyce, take it away.
Thank you, Sophie. All right, so next slide, please. And there should be a poll now. All right, so red flag indicators are one of the ways to help us identify victims of trafficking. The red flags suggest clues or labels that are observed or noticed during an encounter such as a medical exam. So for victims of human trafficking, there are really, you can break it down into 4 distinct categories, as you can see on the screen. Each category helps determine past actions or activities that may be found with trafficking victims. As healthcare providers, a conversation with a patient will help you to identify a possible victim. So let's talk about each of these categories. In the behavioral, you might find that a person could be very withdrawn when they present. They could be happy, they could be sad, they might be reluctant to answer any questions, and you have to wonder why. It might be because there's a person accompanying them. They may have a very scripted history. Their sexual behavior might be inconsistent with their age or their development. And as Sophie mentioned, the interpreter is very important so that if someone comes in a language that you cannot speak, that you get an interpreter who is trauma informed and can be a person separate from the family, quote, family member, or the person who is with them, so that you get an accurate description of what's really the reason for them to come. Now, if you look at the physical categories, you see that there are tattoos. You may ask a pertinent question such as, tell me about your tattoo, or did you get that for a particular anniversary or celebrating an occasion? That might provide you with more information about the person. They may also have some signs of physical trauma or drug and alcohol abuse, as we often see with many of the victims. That might be the one way that they present, as they're asking for help to because of their current situation with drugs. Now, if you look at the clinical category, they may be coming in because of evidence of lack of medical care, such as dehydration or malnutrition. It could also be lack of dental care. You have to remember, patients or victims don't have preventative care. They don't have an insurance plan, so they don't get the care that is often needed. They may come for recurring problems, which would be the actual opposite, so that you might see them for pelvic inflammatory disease, recurrent sexually transmitted infections, and there's often a delay in seeking medical care. These are really important to look at when you're observing the patient, when you're doing your medical assessment. Now, the last category, labor trafficking. Oftentimes they will come in with an injury, and when you ask them about the situation, what you hear from them and what you observe and see during your exam are totally different. So it might have something to do with their abuse or restrictive environment. And it also might have something to do with the fact that they owe debt and they don't really have control over any of their documents. Next slide. Now, screening tools are an important part of preventative medicine. Ideally, screening tools identify patients early enough so that you can provide treatment and avoid or reduce the symptoms and other consequences. In turn, that would improve their health outcomes of this population. But as we know, you're thinking, oh gosh, I already do 1 million screenings. So knowing that you're doing so many different, screenings, how can I fit in another type of screening? So we want you to think about this. Screening tools are there to help you to learn more about that person, and sometimes can be incorporated into ways that you already talk with your patient and other questions that you might ask them. So you have to think when you're asking them these questions as a baseline, at what point are these victims coming in for medical treatment? Are they in crisis? So asking screening questions, is that going to be a big barrier? Or are they seeking an intervention for a specific need, which would be like maybe PID? Remember, being flexible when you're going to be asking questions is really the important key message to take out. You don't want to, be there, ticking off a bunch of questions. You want to really try to incorporate this into parts of your medical exam. Screening is only effective if the victim and the providers are engaged. So it's trying to make that connection. Timing is up to you, and as practitioners, you have developed your own way of connecting with the patient. This is no different. So I want to talk to you about these two screening tools that we have up here now. We'll walk through a few of these, and you can find an in-depth look at them when you read through the screening and the SERV guidelines. The two instruments on this slide are validated tools. Now, validity is an assessment tool. It's the extent to which it measures what it was designed to measure without contamination from other characteristics. All right, so an example of that would be if you are doing a reading comprehension test, it shouldn't contain any mathematical abilities. So you can see that you have to make sure that the tool is specific enough to the questions that you really want to learn more about. All right, so the next slide, please. Okay, so these tools, and remember, no one tool is perfect. The Greenbaum tool, as you can see here on the slide, was developed by Dr. Greenbaum, who's a pediatrician who lives in the Atlanta area. Her team they did a research study and tested these 6 questions and found that they were the most likely to suggest a trafficking victim. So if you read through each of them, they're asking different points about the person. In addition to that, you want to review the medical record. You want to see for previous visits if there's anything that also might indicate, something that might be going on. And as you do that, you want to lead your conversation to focus on these questions to tailor the best treatment intervention. And as you do this, it will also help you to develop a trusting relationship with them. And that then leads to your trauma-informed care. Now, if you score 2 positive responses, then that indicates that it's a positive screen. So at this point, the provider would want to learn more so that they can best help the victim and learn, the level of the risk that is involved as far as being a potential victim of trafficking. Next slide. Now, here you see the quick youth indicators of trafficking. This is a tool that provides a lead into the conversation. So for people who are very used to talking with patients and kind of have worked up a knack for doing that, this is very easy. But for those of you who may be a little bit more uncomfortable, this will help you to lead into asking them really good questions or enabling the conversation to go a little bit further. You'll learn about their daily activities, their safety, their living conditions, and maybe that they might be asked something that made them, to hold a secret, as you might find with younger people. Learning that one of the 4 situations may be present indicates a potential trafficking situation. You can see the 4 areas on the slide. In each of them, control is a big factor and, is kind of one of the predominant areas that they focus on. Next slide. The CUES approach is the broad-based set of 4 topics: confidentiality, universal education, empowerment, and support. This guides the provider on areas of prevention. Through an open discussion, you can learn a lot about the lifestyle of a victim patient and clues as to their safety and overall control of their life. And I can tell you from examining children for many years, it's very easy to just incorporate something and ask them a little bit more about what their daily life is like. Next slide, please. However, there are sometimes barriers between either the patient or the provider. Some providers aren't as comfortable talking about certain situations, and in particular, interpersonal violence. And it might be because they might have something in their life that might lead them to feel that it is difficult for them to talk about it. As with all interactions, victims, there's these barriers because it's a very sensitive area. The CUES method, which was developed by Futures Without Violence, addresses sexual violence, but if the provider's uncomfortable having this discussion, it would be inappropriate for them to say something like, get over it, move on. We have to understand that experiences are personal. Cultural practices may also influence their response, and it does play a strong role in the life of a victim. So if you look at, I know there's a lot to see on this slide, and when you go through the guidelines, you'll be able to focus a little bit more on the different areas of confidentiality, universal education and empowerment, and the support. Next slide, please. As you look at it, there really is no harm in addressing CUES. It's just one opportunity to connect with your patient. Building that trusting relationship without being intrusive can be one of the best things that you can do in the amount of time that you are spending with a victim. Women who talk to their healthcare provider about abuse were 4 times more likely to use an intervention and 2.6 times more likely to exit the abusive relationship. So if you then translate this through human trafficking, you can apply the same principles. So you will be inquiring about their living, their employment, their social environment, and their physical safety. Next slide, please. Now, we do offer many resources for you, and there are a lot of things that you can do with your patients to help them. We don't anticipate that you're going to get a disclosure very often, but we do anticipate that they are going to want to know a little bit more and that you might be able to help them indirectly and directly. So if you look at the different pictures on this slide, you can see that there are shoe cards or hand cards, which are those things on the left-hand side and the very right-hand side. These are, some of them are developed by Homeland Security in their Blue campaign, some are developed by Futures Without Violence, and some are by the PANDA group, who is the prevention of abuse and neglect through dental awareness. These can be obtained when treating patients, and you can hand them to them. They don't like to go out with a lot of paperwork, and so they can slip it inside their sleeve, inside their shoe or their sock. You know, they can put it somewhere where it will not be noticed by the person who comes with them, which is their trafficker. Now, there are other resources available, such as a chapstick, which will have a phone number on it and can help them to reach the national hotline number. And then that way they can ask for help. And sometimes in some of the discharge instructions that hospitals have, in the barcode of the discharge sheet, there can also be a phone number embedded in that, which is another way and a good resource for them when they're looking for something that is tangible for them to have. So next slide, please. Healthcare providers, it boils down, are some of the best resources a victim can have. And there is a lot of research to support that. It is up to us to convey a caring attitude, how we can provide the best opportunity for a patient to seek assistance. We cannot answer all of their questions, but we can help them to know where to refer them to for physical or behavioral health needs, substance abuse, safety, social support, and so on. So I ask you to think about that when you're working with your patients. Now I'm going to hand it off to Dr. Jessica Voles, who will provide how to respond to trafficking survivors, as well as how to evaluate your program by collecting and analyzing data to ensure effectiveness.
All right, thank you, Dr. Williams. I am really excited to be part of this group and present this section to all of you and bring it full circle. I hope everyone can hear me. If you can't, or if I'm a little too soft-spoken, sometimes people say that I am, just let me know. So I just wanted to start off, you know, yesterday I read a study that was published last month, and it found that only 30% of patients presenting to the hospital for a sexual assault have a primary goal of evidence collection. Only 30%. And I think this is a common misconception. I work with a lot of professionals who encounter my patient population, which includes trafficking survivors. It includes survivors of sexual assault and abuse. And they say, I'm really nervous, I don't know what to say. And I really wanted to kind of highlight this study because it demonstrated to me that people are presenting to you for what you do best. This is true, also true of patients experiencing trafficking. They're presenting to you for what you do best already. So you have the vast majority of the tools that you need to care for this patient population. I was hoping that knowing this and reviewing the materials in this presentation, especially in the response section, will give you confidence when you're approaching patients who have experienced trafficking. So the response section is very versatile and is part of the model that's designed to be adaptable to various settings and organizations. So we recognize that every organization is going to have different resources, every community is going to have different resources, but this section in particular is really adaptable, and I hope that if you have any questions at the end about how you can make it adaptable for your organization or community, that you feel free to ask those. So the response section says that the guidelines recommend that hospitals respond to trafficking survivors by providing the option to be connected with a specially trained community-based provider if desired by the survivor. And I believe we have a poll before the next slide. If we could take just a few seconds to answer this question. Jane, how are we doing?
Good. We'll give it probably about 10 more seconds to collect responses.
Thanks. Okay, and we'll see the results here. So my current institution has adequately trained its healthcare providers to provide care for patients who are trafficked persons. And the majority of you, 56%, disagree, and 19% of you strongly disagree. So I would say that most people here on this webinar don't feel that that their institution really has trained its healthcare providers. So I'm glad that you're here. We can close that poll, and here it is again, the recurring theme, a trauma-informed response, right? So this is talking about the next step for safety and stabilization, community and collaboration building, a warm handoff, and after discharge response. So what we see here with this trauma-informed response is that trust is really a recurring theme throughout this model and the care that should be provided. How can you do this? Number one, sit with the patient. It is evidence-based that if you sit with your patient instead of standing, they perceive that you spent more time with them. Be aware of your body language, your eye contact, and touch. Always ask permission to talk to the patient and give a thorough introduction of yourself. As Sophie had mentioned, as healthcare providers, oftentimes we expect that there is this implicit trust of our patients, even if we just met them, that they trust us, that they should trust us. But this is a little bit of a different dynamic. So you want to make sure that you explain who you are, what your role is. Many of these victims have perfected their survival skills and can really sense how you are feeling. So making sure that you are conveying genuine care and belief of what they're telling you. I review cases from all across the state and charting from all across the state for various purposes. And I've seen documentation all over that says things like patient alleges, or patient claims, or the patient is accusing. So what I would challenge you to do, and we're going to talk in a little bit about documentation, is to set the tone in your mind, your demeanor, and identify bias before you initiate the encounter. The next part, setting expectations, right? So we want to anticipate needs, educate and inform. We want to work as a team with the patient and make sure that we're providing autonomy. Autonomy is really important to this patient population and giving the power back to them. And part of that, anticipating the needs and trust building, is also being sure that you're not making promises that you can't keep. So one thing that I always like to tell providers is you might not be able to make many promises for these patients who are feeling unsafe, but what you can promise, and it can be a genuine promise, is that you're going to do your best for them. And that's a promise that no one else can make for you, and it's a promise that only you can keep, so it's within your control. So that building and trust and rapport really begins there. I believe we can go to the next slide. And talking about next, establishing treatment priorities and goals. So this is all part of the safety and stabilization, right? We are all trained here as healthcare providers. You might be a social worker, you might be a physician, you might be a nurse. All of us are familiar with Maslow. And I really like to go back and focus on such a basic concept of anticipating basic needs first. So if you haven't had food in a day or two, and you are dehydrated and you may be going through withdrawal, you aren't interested in talking about therapy. You really want to have those basic needs met first. And so meeting the patient where they are, stabilizing them in that way, a sandwich and a warm blanket frequently go a very long way. So keep that in mind and attempt to understand what the patient's perceived needs are versus what you believe their needs are. And also you want to make sure that you're identifying barriers that are both real and perceived, and make sure that you're discussing those with the patient, right? I like to tell my patient that we're a team, and that we're working together, not against each other, and that their goals are my goals. Talking about fostering social and community reintegration and providing appropriate referrals to community-based service agencies. So looking at giving the power back to patients. Learning your role is really that of a facilitator, and being sure that you articulate and acknowledge this with the patient. So frequently with patients who have experienced trafficking, I think of a saying that someone told me when I was expecting my first child, and they said, raising a child is like holding a bar of soap, a wet bar of soap. So if the child, or in this case, if someone that you're trying to establish trust with, a trafficking survivor, right? If you hold it too loose, it falls out. And if you squeeze it too tight, it shoots out. So we want to hit that happy medium where patients understand that they're safe with us, but also that they're not trapped with us, and that they don't have to, that their plan of care really is based on their own guidance. We want to make sure that we're providing appropriate referrals to community-based service agencies, and this is really important to know your resources. Use the resource guide that Jane is going to be sending out after this presentation, and that you're individualizing the plan and offering multiple options when possible. So options, yes, they can be overwhelming, but having one or two options, or asking, what was your previous experience like with, and then provide the agency that would be maybe your top choice for this particular patient. Because many of them may have had an experience in the past, positive or negative, with one of the organizations that you're recommending, and you want to have that feedback. Next slide, please. Community and collaboration building. This is really important. Looking at your partnerships with law enforcement, other healthcare organizations, legal organizations and support, and social service providers. You want to make sure you have a list of updated local resources and have an internal algorithm with localized resources. So looking at these partnerships, that's really, we operate as a multidisciplinary team, understanding that each other has a unique role, different abilities and limitations, that the approach is going to be different. A victim advocate is going to approach a situation much differently than a physician will, or much differently than an attorney will. So keeping that in mind, that you can utilize each other's strengths and develop a plan ahead of time on how you can work together. For your list of local resources, as mentioned, referring to the resource guide, that's a great place to start. And looking in your community to find out if they have their own local task force or committee that addresses human trafficking. One really important thing to look at is the mental health crisis response and shelter placement, including emergency shelter placement within your community. What does that look like? Who do you call? And what are your patients' options going to look like? Finally, in developing the internal algorithm, I would recommend highly, as does this model support, developing this as an MDT, a multidisciplinary team. So you want to make this work for the team. And looking at the community resources that you have, you want to make sure that you're bringing all of those folks into the fold. This also can really help to identify gaps that exist within your organization and within your community so that those can be addressed ahead of time. Next slide, please. Okay, so this is a very busy slide. It looks very exciting because we have several different human trafficking healthcare response protocols, internal protocols, for hospitals. These are specific for hospitals. And what I'd really like to point out, I know that there's a lot of information here on this slide, is one, they all start with identification. And really part of a cornerstone of identification, you know, sometimes patients, I'll say to them, so why did you feel like you couldn't tell anyone about this situation before? And they will frequently say to me, because no one ever asked. So again, like Sophie said, you don't want to ask probing questions, but ask enough questions to elicit the information to identify someone. Encourage a trauma-informed approach. All of these models support that, including speaking with the patient alone and providing resources. So if you don't look through all of these algorithms independently, the most important thing for you to know is start with identification, respond in a trauma-informed way, speak with the patient alone, and provide resources. And one great way to get the patient alone, given the recent pandemic, one of the few things that are positive coming out of this is really that you can utilize that to speak with your patient alone, because most places aren't allowing visitors or have a very limited visitor policy. Next slide, please. The SERVE model in particular, and you will get a packet sent to you with the model at the end of this presentation. This algorithm also incorporates these concepts and is broken into adult and youth. So here is an example for adults. It has a medical focus and provides sample diagnosis codes. And if we can go to the next slide, please. Here is the example of a youth algorithm based on the SERVE model. The big thing to point out here is, again, in developing rapport, I always would encourage you to, once you're getting to a point where a disclosure is occurring, making sure that you are as transparent about what constitutes a mandatory report as possible. That really is a way to quickly erode someone's trust if they tell you something and then suddenly you say to them, I'm going to have to report this whether you want to or not. So what I would recommend is presenting that as kind of in their own terms, what's going to constitute a mandatory report, but most importantly, why mandatory reporting exists, so that you're acknowledging that some of these things that they're going to talk to you about are really tough to talk about, and that they may not be ready to participate with, for example, law enforcement, but that your primary goal is their well-being and their safety, while providing as much autonomy as possible. Another thing that I really would like to point out in this youth algorithm is the Safe Harbor Regional Navigator Grant Program. This is designed for youth ages 18 to 24 years old, and I have referred personally several patients to this program, always with very positive outcomes. And however, I am not an expert on the program, but Sophie is. So I am going to turn it over to her for just a few minutes so that she can give you a little bit of information about this Regional Navigator program.
Thanks, Jess. All right, so excuse me, this is our Child Sex Trafficking Screening and Services Act of 2019. So this was legislation passed in last year's session that from the governor's office, which is now, used to be GOCAP, is now the Governor's Office of Crime Prevention, Youth and Victim Services. And this was a program established to ensure that every suspected sex trafficked individual under the age of 25, so Jess had mentioned 18 to 24, I want to be clear that it is anyone under age 25. So it's all youth and minors and then up to the age of 24. And in its first year, the program was piloted with the Cecil County Department of Social Services, the Washington County Department of Social Services, and then the University of Maryland Safe Center served as the regional navigator for Montgomery County. We are now in our second year of funding, and we've expanded to 11 jurisdictions. I'm going to name them for you so you're aware of them. It includes Baltimore City, Anne Arundel County, Baltimore County, Frederick, Harford, Howard, and Prince George's County. Plus, we've stayed in Cecil, Washington, and Montgomery counties. And I'm saying this because if you are in any of those 11 jurisdictions, welcome. You now have an identified regional navigator in your county or in Baltimore City to work with you if you suspect an individual under the age of 25 is a victim of sex trafficking. This is only a sex trafficking specific program. So the point of this program, the goal was to increase the awareness in the state of Maryland of sex trafficking for youth and folks up to the age of 25, to identify these potential victims, to really leverage this MDT approach, working between DSS and the welfare system, law enforcement, other youth serving organizations in the area, to work with the regional navigator to ensure that this suspected victim receives holistic care, and that they can be connected to services that include, but are not limited to, certainly you see below here, these safety planning, emergency response, living needs, trauma counseling, drug and alcohol abuse treatment centers, legal services, victim advocacy, and case management. So you all as hospital folks, if you're in any of those 11 jurisdictions, which again, Jane will send out these resources afterwards, you have an identified regional navigator. They are the one who can specifically support you in cases of suspected sex trafficking under the age of 25. I also want to add that after this webinar, and we should kind of keep it moving a little bit for the sake of having some questions at the end, Jane will send out a world of resources to you all, because really, as Jess is emphasizing here, what is important is for, as Joyce said, know what to look for, and then as Jess is saying, know who to call if you think you're seeing it. So I really would encourage you all to take a look at the resources in your area. All right, Jess, we'll pop back to you, and we'll try to wrap it up in just a minute or two so we can get to some questions. All right, there you go.
Okay, sorry about that. I couldn't unmute myself. So, okay, here we are back. And just a real quick, you know, I know that anyone under the age of 18, we're used to calling CPS. You will still call CPS if you're suspecting trafficking, but I cannot tell you enough what a resource the Safe Center is. And so what we will frequently do is make sure that our CPS is connected with the Safe Center, and that we form this team. And I really would just encourage you to don't hesitate to utilize their services. They're absolutely wonderful. Talking about a warm handoff is next. So talking about moving forward as a team, making sure that once you've established that trust and rapport with a patient who is likely or suspected to be or confirmed as trafficked, you have established that rapport, and it's really important that the next person that you're handing care off to becomes part of that patient team. And the best way to really do that is for the new person coming on and yourself to talk with the patient and let them know this is someone, if this is somebody that you work with almost every day, say, this is Jane. I've worked with her for years. She's really wonderful. She's going to continue to take great care of you, so that they continue with that trust and remain engaged. If we go to the next slide, please. So after discharge, this is going to be survivor driven. Know that resources are available, but not mandated. work to reduce barriers between patients and service providers, and making sure that you are familiar with law enforcement and mandated reporting. So just remember that this response should really be patient-centered all the time. I would really encourage you to look at the relationship-based care model, especially this is a nursing model that's become very popular, and I wish we had time to kind of go over some of the nuts and bolts of it today, but it really pairs very well with working with survivors of trafficking. Remembering that we are preserving autonomy throughout, so letting them know resources are available, but not mandated, of course, unless they are. Making sure that we are working to reduce these barriers. And step one of that is identification, right? So identify with the patient what the barrier is. Is this barrier real? Is it perceived? Is it both? And how do we overcome that together? And then with law enforcement, again, just being transparent about the mandated reporting from the very beginning. Next slide, please. Evaluate. This is the last part of SERVE, and the guidelines recommend that healthcare providers collect and analyze data regularly to ensure that the model is effectively identifying and providing care for survivors of human trafficking within their facility. So again, this is really designed for you. Next slide, please. Okay. Looking at these ICD-10 codes, we wanted to provide you, if you are a provider that assigns a diagnosis code to patients, these are really useful in helping track your patient population. And I want to point out here, it says confirmed or suspected. And what I would almost always encourage you to put is suspected, because confirmed it can become legally very tricky, and having to kind of defend your decision if it comes to a legal proceeding on why you stated that this was a confirmed case of human trafficking can really become quite tricky. Next slide, please. So why are they helpful? They offer, of course, a more adequate diagnosis classification. They help to expand our understanding of the risk factors and comorbid illnesses. So if you have a dental complaint paired with a diagnosis of suspected sex trafficking, and you're seeing that over and over again, it's much easier to run that data for your own practice changes. It allows us to collect information on the cost of treatment for human trafficking, which is incredibly important. And it's really also important to talk about the safety and legal concerns with displaying the codes. I'm going to talk a little bit about this in the documentation piece, which is next. So documentation tips. If you are going to really change your practice, aside from being more trauma informed, I would say this is one of the biggest areas to focus on. So you want to balance the need for information with medical legal discretion. So obtaining information about prior injuries, STIs, consensual sex, etc., might influence an exam or the resources offered by the healthcare staff. But documentation of this information may be used against the patient in certain legal circumstances. So always consult with a local attorney familiar with privacy and rape shield laws. I thought that I knew this really well, and I recently was very surprised to find out a past sexual assault that was reported, and it was documented in the chart that the judge actually did allow that to come into the legal proceeding. So just keep in mind that the information in the medical record can potentially be harmful to the patient when their case goes to trial. So be very mindful, not just about what you're saying, but as the old saying goes, it's not what you say, it's how you say it. So I have sometimes run across, again, as I said earlier, patient alleges, patient claims, patient is accusing. If a patient is experiencing chest pain, we don't write the patient alleges they have chest pain or the patient claims they have chest pain. We say that they're reporting chest pain to us. So think about what some alternatives are to saying this. And I think it's because it's tied to such a social issue and that psychosocial piece but that casts doubt, right? And we don't doubt that our patient is having chest pain. So why would we doubt what this patient is reporting to us? I have seen in charts, again, from all across the state and on a national level even, patient reports sexual assault, which I highly doubt. Or things such as patient says she frequently prostitutes and has sex for money. I actually look at these things and think, and keep this in the back of my mind, even in my own documentation. Okay, how is this making a bearing on the medical treatment or the safety plan for this patient? If it's not, is it really necessary to put in the chart? And how you're documenting is often, if you go back and read your documentation, a reflection of how you might actually be treating the patient and what they're getting from you. I had a patient actually, and this will stick with me forever, and so I feel like I need to tell this group, who said to me that I was the first healthcare provider that didn't look at her like, and these are her words, a dirty hooker. And that has always stuck with me. And if you pair that with some of the documentation, if you really review some of the documentation, please be mindful of that. Think about how this is stored. Keep in mind that your patient is going to potentially have access to these records. Imagine getting your medical record and reading patient reports sexual assault, which I highly doubt. And keep in mind that sometimes parents will have access to these records. So, I kind of like to jokingly use the analogy that this is not Dear Diary, right? So keep it, what do you need to know for the health and safety and what is not relevant? Can you work with your system to protect parts of your documentation? And make sure that you're using appropriate language and quotes where possible. So I just wanted to, this is something that I could probably do an entire lecture on, but we are running short on time. So I just wanted to point out in conclusion, that many jurisdictions, crimes committed by trafficking victims, while under the control of their traffickers, will be prosecuted. So please keep that in mind in your documentation as well. I know that seems hard to believe, but it happens. And that the information gathered during a forensic exam, including photographs, may be shared with the defense attorney and sometimes with the traffickers themselves. So not only are your quotes and your documentation going to be potentially released to the patient themselves or their parents, but also to even in some cases, the traffickers. So I know we are running very short on time. I believe Sophie is going to take us through a case study after we wrap up, and just remind you that SERVE is serve, identify, respond, and evaluate.
Okay. Well, we made it, team. As you can see, we all have quite a lot to say about this. I want to just wrap up, and we're going to skip the case study for now and open up for just a few questions. I hope that the information that we have given you has been helpful in terms of trauma-informed care, tips to identify those red flags, how to respond, build your network, and then evaluation. And yes, Jess has a unique passion for documentation tips, so we thank her for that. So we created these guidelines to be adaptable for whatever setting you're in, for you to be able to take something from them. We're going to skip the case study. As I said, I want to leave you with our contact information. Jane, you can launch our last poll. When you all finish the poll, that poll screen should disappear from your screen, and let's have a few minutes for questions. So put those in the chat. We'll give you, 2 minutes or something to do this, and we've left you a big 5 minutes for questions.
Thanks, Sophie. So while people are working on the post test, you can also unmute yourself if you do have a question or raise your hand. But maybe let's start with what we've gotten already in the chat. So why are tattoos a physical red flag? When the majority of the population has tattoos, are there particular ones that are more a red flag than others? And I think Joyce might be able to respond to this.
Okay, I had trouble unmuting. Sorry about that. Okay, so tattoos can convey a lot of different things. It's a constant reminder that they're the property of somebody. So that's kind of a demeaning role. So you want to think of it in that way. And there are different types of pictures or words that might convey something special about the trafficker. For a long time, the crown was a really important one. Then they kind of went to barcodes. And then they've gone to a variety of other things. So it's sort of what becomes popular at the time. And it's also ways that the trafficker sometimes wants to find something new in some way for them not to be found out as to who they are. But it's really a thing of ownership. Now, some police agencies also keep kind of a photo album of a lot of different tattoos. So you should talk with your, law enforcement in your locale and see from them what they, can help you with as well. But it's just that they want people to know that you are mine. And so you might see them, like I said, sometimes in the lip is one place that you can see it because it's not visible to others, but it's visible to the person. Or they will put it sometimes on the thighs. There's a variety of places. They used to do the neck a lot, but it just varies from time to time. So you just have to kind of figure out what's going on in your particular area. So I hope that helps.
Great, thank you, Joyce. The next couple of questions that were in the chat relate to children and involving Child Protective Services. So should the police be called as well as Child Protective Services for patients under 18? And then if you suspect a parent is trafficking a child, how do you handle this? And does it go straight to CPS?
So under Maryland law, human trafficking is categorized as a form of abuse. So as mandated reporters, you should call your local DSS if you suspect human trafficking. In jurisdictions that have this regional navigator program, law enforcement by law will have to be looped in. But yes, you should definitely call your jurisdiction's DSS. Jess, do you have anything to add to that?
I would just say that it's really important to know the relationship that your law enforcement that would be handling these cases has with DSS. And that's really part of being part of the multidisciplinary team. There are some cases where, for example, if a parent is trafficking a child, we're going to be bringing law enforcement in early because this is all traffickers have care and custody. However, someone that lives in the home with this child, so the law enforcement piece, I would say, touch base with your multidisciplinary team. Touch base, especially with DSS, and also touch base with your risk management or with your general counsel, whoever you have within your organization that can help you make that decision.
Great, thanks, Jess. And it looks like we have another question from Ashley. How do you distinguish between sex trafficking from voluntary sex work? And then would you respond differently in the way you provide care to the patient?
So the thing that sets sex trafficking, oh, you'll have to excuse me, Jane, I already forget the second part of the question, so you can tell it to me after I do the first part. The thing that sets sex trafficking apart from traditional sex work is this element of force, fraud, or coercion. So if someone is engaging in that sex work as a result of force, fraud, or coercion and does not feel like they can stop if they want to stop, that is sex trafficking. Plus, in the case of minors, anyone who's under the age of 18, anyone who is engaging in commercial sex, So exchanging sex for anything of value. So exchanging traditional sex work, prostitution, stripping or dancing, pornography, any kind of sex work for something of value. So it could be money, it could be material goods, it could be jewelry, clothes, accessories, anything of value. It could be a cell phone, it could be safety, it could be a relationship, it could be a phone.
Couch to sleep on.
Say it again.
A couch to sleep on.
Right, a couch to sleep on. So any minor, anyone under the age of 18 who is exchanging sex or a sex act for anything of value, that is considered human trafficking. Jane, remind me of the second part.
Sure. Would you respond differently in the way you provide care to the patient if it was a sex worker versus trafficking?
Yeah, so from a victim services perspective, I will say that I would both go with the cues approach. If they're adult, I really emphasize universal education, educating the patient about their options, normalizing their activity, telling them what's available to them. If it's trafficking, I would say try to connect them with a trafficking specific agency if you can. And if it is trafficking, it will be a little bit more complex, could be a little bit more nuanced in terms of getting them those supports and getting them those resources. And you might have to figure out some creative ways to get those options to the patients. Anyone else want to add to that?
I would just add that I've worked with a lot of patients who who are taking part in commercial sex work and are not trafficked. And what I would say is, really sitting down and talking with them, is there anything that I can help you with resources? Because frequently what we will find is that it's maybe a mother who this is not her first choice. And though she is the one, putting herself out there for this purpose, and there is not a trafficker involved, certainly, I've run across many, many situations where it doesn't mean that the person really wants to be selling themselves for sex. So I think that's a really important dynamic to acknowledge. Now, of course, there are going to be people that don't fit into either of those two categories, but just really being understanding and developing that rapport.
Yeah, I would add that we have something that we talk about quite often called survival sex, folks who have sex for money just to fill their basic needs. I have had plenty of experiences where folks tell me that they're having sex to get Christmas presents for their kid, or, to put dinner on the table. And there's not someone standing over them, making them do it or keeping the quota or anything like that. But there is a lot of sex just to get by, especially in a time of COVID, I would add, where a lot of people are losing their jobs and are having, way more trouble making ends meet. Sex for money will always be there. It's been here since the beginning of time.
Great. Thank you, Sophie. And I want to be respectful of everyone's time, but we have one more question and then we'll wrap up. Are people who are trafficked for forced labor at risk for deportation?
So we do have some, there are 2 visas that are available to folks who are victims of trafficking. So we have the T visa. Those are folks who are victims of severe forms of trafficking. And there's a U visa for folks who are victims of severe forms of abuse. And there are 2 things that there's a million things that can make it complicated, but 2 specifically, which are that under our current administration, it has been a lot harder to get our T visas granted. Come January with a new administration, we might be playing a different game. The other thing is that for someone who does not have legal status, who is a victim of human trafficking, to be granted a visa, they have to cooperate with law enforcement. They have to report their trafficking. And that's hard. I would say that if you have folks who do not have status and you believe to be suspected victims of human trafficking, you can call the Safe Center where I work. We have a bilingual English-Spanish legal team. We also have access to the language line, and our attorneys can do screenings to figure out if some of these folks are eligible for a T or a U visa. Again, it's one of these things where the fear of deportation is very real. It's a form of coercion. It's a way a trafficker can keep someone in their trafficking situation by threatening abuse of a legal system, threatening reporting someone who doesn't have legal status in this country. We would encourage you to get in contact with someone who has, a trafficking trained attorney who can do a screening with that person.
I have a question. I mean, I know you have to end. Is there a way that I could stay afterwards and ask you a question?
Sure. Yeah.
Sure.
For those that have time, we can, as long as our panelists are okay, we can extend it a little bit. We did promise to make this interactive. I do want to note, Jess put in information on the CEUs, and so you'll be getting a course evaluation by email, just for those wanting to participate in that. So yes, Ms. Contreras, go ahead.
So I'm not 100% clear yet on the definition of like how to make it work. And so I had a kid recently that reported to me that while living in Nebraska, her mother sold her to a man who forced her to engage in anal sex. And she said the mom got paid. So is that considered human trafficking, for example?
Mother's trafficking.
Okay, so I reported that to DSS, and so the kid is actually now in Baltimore, ended up staying with a family that she randomly found. DSS didn't remove the kid from there, left her where she is, but she's still a minor. So is that a case that I should refer to you guys?
So you referred her to DSS.
DSS went to the house where she's staying because a random lady from the community has been taking care of her for the last year. Mm-hmm. But DSS left her there and didn't do anything else.
Okay. Yeah, you can certainly refer her to us. We'd be glad to do a screening and open up the case.
Okay. And then one more question. If a parent, because someone was asking me about this, I had another case where possibly the parents of a 21-year-old has all her documents and apparently wants to send her out of the country to get married. And so I'm supposed to see her sometime in the next few days, but that's not quite trafficking, right? So what is that? Like they want her to force her marriage and to marry outside of the country with a cousin.
We don't deal that much with forced marriage.
How old is she?
She's 21.
So, I mean, that's something we can certainly talk about offline. I have some resources for you that are not trafficking resources, but legal resources for individuals that are experiencing, forced marriage or like, for example, female genital mutilation. So I can provide you with some resources for someone in that situation.
Okay, thanks.
And just for the sake of getting all the questions, there was one in the chat from, looks like Aaron. Are there any changes you would make in regards to your documentation and the setting of the CARES Act?
One thing I can tell you is through Epic, you have the option to share with patients. There's a feature that's activated by default. So if you don't deselect it, it could make that note available to patients, parents, or others. So I guess it's learning what is in your particular medical record and talk with your IT department and know when the share button should be on or off, and that might help you. There is a big discussion going on right now on the HEAL trafficking website. So that's another resource where you can look for different information pieces.
Great, thank you, Joyce. Are there any other questions before we close? Okay, I don't see any. I want to first thank our presenters. They are amazing and experts and have really been a guide for us here at the Maryland Hospital Association. And thank all of you. I know you're incredibly busy as we're surging with COVID. So I appreciate you taking the time. We will share all of these resources with you in a follow-up email. And of course, we're always here to answer questions. Sophie with the Safe Center, Jess with Adventist Healthcare, and Joyce and Dave with the Human Trafficking Task Force. So thank you all again, and we'll be in touch. Thank you.
Thank you, Jane.
Thank you.
Thank you.